that can be translated to what we may expect from this current pandemic. And then I want to talk about my experiences with the pandemic I had to deal with when I was the director of the Ohio Department of Health. And that was back in the late 80s, and that was the HIV pandemic. And try to talk about some of the factors that can negatively affect the outcomes of that HIV and show how the same thing is happening with COVID-19. So to look at a historical perspective, when we say pandemic, we really mean an epidemic that has crossed international borders. And with this, at this time, COVID-19 has crossed all borders, and essentially there's really no place on earth that is free of this disorder. Pandemics have been around for a long time. As a matter of fact, archaeologists found that in China 5,000 years ago, they found evidence of what was a pandemic. And because the world was a lot smaller then, a pandemic didn't have to travel that far to cross borders. But they noted in a hut that there were multiple corpses, and they had died so quickly, the population didn't have time to bury them. So pandemics have been around for quite a while. The worst modern pandemic, and perhaps the worst pandemic ever, was the 1918 Spanish flu that raged across the world from 1918 to 1920. And this was caused by an H1N1 virus. Researchers went up to Alaska, to the frozen areas. They found bodies, and they were able to extract tissue so they could determine the type of virus that was causing this. But this Spanish flu, as it was called, was horrendous. It killed 50 million people worldwide. And in the United States, it killed almost 700,000 people. It was noted that 1/3 of the entire world's population had been affected by this disorder. And it's interesting how it laid out. It came in 3 waves. The first wave was noted in the spring of 1918. COVID, March. Any familiarity? The second wave occurred in the fall of 1918. And then the final wave occurred in the winter of 1918. Now, because there was no modern virology science, there was no active scientific method to defeat the virus. No therapies, no vaccines, nothing of that nature. And so what enabled the people at that time to rid themselves of this virus? Well, interesting enough, it was quarantining, wearing masks, and because it had affected such a vast number of people, they eventually developed herd immunity. And herd immunity is when a large number, generally over 70% of the population, has been exposed to the virus. They develop antibodies to protect themselves. And so with that, the whole community tends to be protected. So again, just to show how things repeat themselves, even when we compare the medical science of 1918 with the medical science of 2020. Now, most pandemics are known as zootropic, and that means they come from some animal vector. And there's always this big question that everyone has raised, how did COVID-19 start? And a lot of people talk about, bacteriologic, virologic warfare and things of that sort. I have a lot of colleagues in China and India, and we've pretty much worked out how this happened. And let me first give you this concept. There is a realm of virology research called gain of function. And this is a type of research in which you want to try to find out as much about a virus as possible so that you can predict how it might react sometime in the future. What that does is it's a process that actually modifies the genotype, so it changes the virus. And sometimes they're trying to find out if the virus can be transferred into other species, or it may move from other species into humans. Unfortunately, some of the side effects of that is to make it more transmittable and more virulent. There is only one level 4 biosafety laboratory in China, and that is the Wuhan Institute of Technology. And Wuhan, as you may recall, was the place where the virus was first noted. We are aware that they were doing research on bats at that time. And regrettably, they were also doing gain of function studies. Now, the Wuhan Institute was only approved for its level 4 status as of 2015, so fairly new to the activity. We know certain things. We know that they had a lot of young and inexperienced people working there. We know that they weren't paid well. And so this set up a rather unfortunate circumstance. One of the animal vectors that they were working on is a creature called a pangolin. It sort of resembles a small anteater armadillo, but it is the only mammal that has scales. Because of that uniqueness, in the Orient, it is seen as almost a magical type of creature. And so the cost for that particular meat of that animal can go up to $1,000, $2,000 a pound. And so one can see how there might be a temptation to pilfer some of those test animals and sell them on the open market. And Wuhan is well known for what they call a wet market. A wet market is essentially a market that sells fresh produce, meats, fish, things of that sort. And it is felt that because these research pangolins wound up on the Wuhan market, they spread the infection to the human population, and from there it went on. It wasn't purposeful, it was an accident. And unfortunately, there have been a lot of concerns about gain of function research. In the United States, it had actually been prohibited. However, recently it's been reinstated to be allowed. And I feel that the public really needs to take a close look at gain of function studies. It certainly can allow you to gain more information, but the dangers, the risks, I feel, outweigh the possible benefits. Now, again, we've suffered through a number of pandemics, and I'd like to focus on the 2009 H1N1 swine flu. Now, unlike COVID, this viral disorder affected children and young adults, generally people less than 65 years old. The older people, it was felt, had prior exposure to similar viruses, and therefore their immune systems could recognize and fight the virus. The rapidity of which things happened was pretty unusual. Swine flu was declared a pandemic in June of 2009. And over that period, short period of time, it was responsible for 575,000 deaths in the world. 2 weeks after it was declared a pandemic, we had developed a test to identify that disorder. And even more remarkably, in December of 2009, we had developed a vaccine for that disorder. So a very rapid occurrence of things. Unfortunately, things with regard to the virus were quelling, and so the mass production and distribution of the vaccine was felt to be unneeded at that time. We can also take a look at the fact that there have been other coronavirus infections. In 2003, we had SARS, and that has been, we've not really identified the type of animal from which it came. In 2012, we had MERS, the Middle East Respiratory Syndrome, and that came from an avian species. Chickens, because the way they're raised and because they're bunched together and because there's such close contact with humans, are going to be a species that we really have to take a close look at because of the potential for that to spread a pandemic. So that just gives you some ideas of what has happened. I would also mention one other aspect. With regard to the swine flu, it appeared to be regressing, appeared to be slowing down. However, in September of that year, when the schools reopened, a second wave occurred. So just a little warning about what we're anticipating. Now I'd like to talk about what occurred during my tenure as director of the Department of Health. I was confronted with HIV. And first of all, let's kind of compare HIV to COVID. I consider there are two types of viruses. One I would consider an active transmission and the other a passive transmittable disease. An active transmittable disease is one in which you really have to purposely do something in order to get it. A passively transmittable disease is one that can occur, you can get the contagion by essentially just being in the wrong place. As with COVID, we know that it is spread by particulate matters that are expelled from the nose and the mouth and exist in the air. And if you walk into that and breathe that in, then you have inhaled the virus. Also, one can contract the disease by coming in contact with infected surfaces. So that's one of the differences, active versus passive. HIV was an active disorder because people that got HIV were generally gay men and IV drug users. Now, there's several phenomena that can have a negative impact and something that we have to combat. And the first one is that a lot of times there is a stigmatized population that is affected by these viruses. With HIV, that stigmatized population was, again, gay men and IV drug users. There was a difficulty with regard to compassion. Many people felt that because they had a lifestyle that was contrary to what they believed was appropriate, that their dying of AIDS was simply God's punishment for them being bad people. And so we had to raise the level of compassion and understand that a pandemic can affect everyone. And that's another difficulty that occurs. People believe that if someone looks well, then they are well, and that's not true. And I'm going to talk about something called universal precautions in a little while. But with regard to COVID-19 at this time, the stigmatized population are the elderly and nursing home residents. We hear a lot of folks on television, on network news. Some noted people have said, well, you know, these people who die from COVID, they're in their 60s and 70s, and they've pretty much done all they could do to contribute. So if they die, it's not really that big a loss. Or I also heard one of the senators say that the elderly should be willing to make the ultimate sacrifice to restore the economy of this country. As well as a comment that said, well, since this disease is only killing 80 and 90 nursing home residents, I don't really see why we have to take all these quarantine precautions. They're going to die anyway, so why worry about it? And again, stigmatized populations, and that's part of the difficulty. And why I say it's part of the difficulty is there's a philosophy called universal precautions. And that philosophy states that you assume that something can be of harm to you rather than assuming by observation that something looks good. And I'll give you an example. Supposing you're walking down the street, you look down and you see a needle, and that needle is dirty, that needle has blood on its tip. Well, you look at it and you immediately say, this is something I don't want to have any contact with. But then let's say you're walking down the street and you see a needle and it is clean, there's no evidence of dirt, it looks quite new, as a matter of fact. And because you want to make sure that no one steps on it, you pick it up and you toss it in a trash container, assuming that it is safe. But simply by looking at it, you can't really tell. That could be very well affected. And so universal precaution states, assume that you can put yourself at harm by doing certain things. And don't assume that simply because something appears to be safe, something appears to be well, that it is. Always have a bit of doubt. And with that bit of doubt, if you know the potential is there, then certainly with regard to COVID, you see young people frolicking and you say, oh, they're healthy, they can't have COVID. Well, they can. And so you wear a mask, you social distance, you wash your hands after coming in contact with any surfaces. You try to avoid touching your face. So you do the things that are precautions all over the world. Now, with HIV, we stigmatized that certain population, but it expanded into other populations. And one of the reasons why, because simply looking at someone, and let's say a gentleman has a three-piece suit, is carrying a briefcase and looks very prosperous, does not mean that they could not be IV drug users or have some other risk factors that put them at higher probability to have the disease and therefore pass it on. Again, universal precautions. Always assume that danger is there and do everything you can to protect yourself from that danger. At this point, we know that HIV was quelled by doing certain things. But then, besides the stigmatized population, our greatest enemy in viral pandemics is complacency. At some point in time, people say, well, you know, I've been in my house for too long, I've been wearing this mask and it bothers me, and things look like they're getting better. I see numbers going down, I see people out and about, and so maybe I can just relax and not have to worry about those precautions. And that's the complacency that is dangerous. When I dealt with HIV, people started to become complacent. And I saw certain habits that really were frightening. There was a group of young women that I called the donor darlings. And these were young ladies who had partaken in, let's say, unprotected activities that could expose them to HIV. But because they were embarrassed, too embarrassed to go to their family doctors, they had to find a way of testing themselves without really having a lot of public scrutiny. And so what they did was they went to the Red Cross, they volunteered to give blood under the assumption that the blood would be tested, and if they had the virus, they would be informed in a relatively anonymous way. They didn't consider the fact that they were putting the whole blood supply at risk, because initially we did not have good testing for blood to detect HIV. And you may remember the famous tennis player, Arthur Ashe. Arthur Ashe had a difficulty and had to go under surgery. He received transfusions, and regrettably, those transfusions contained HIV, and he perished from that disorder. So again, just to kind of let you know with regard to that. Now, with regard to COVID, as I mentioned, we have a stigmatized population. And certainly with regard to complacency, we're starting to see that. Individuals are refusing to wear a mask. They state that this is contrary to their First Amendment rights. But I would remind them that you have the freedom of speech. But as the old adage goes, you don't stand up in a theater and yell fire, because you know the outcome would be disastrous. And so wearing a mask is not necessarily protection for you, but it entraps those particles that come from the nose and the mouth and prevent them from circulating into the air. And therefore, with those particles not being in the air, another individual cannot inhale and ingest the virus. So those are some of the things that I learned. The other circumstance is that at a certain point, there seems to be a politicized agenda for a virus. With regard to HIV, it was the fact that people were suggesting clean needle programs. People were suggesting the use of condoms. And there were a number of religious people who felt that this was contrary to what they felt was a moral approach. I actually got into a fair amount of controversy when I promoted an educational program for college students that explained how condoms could protect them from HIV. The opposition was enraged by this, and I actually got the unflattering nickname of the Condom King. So actually, it became such a controversy that during the time when the Berlin Wall was coming down, when President Bush was coming through Ohio to campaign for his reelection, the #1 story on every front page in the state of Ohio was the condom controversy. It got to the point in which it actually was an international affair. I was actually interviewed by the BBC about the condom controversy. So again, those three things we have to be concerned about. Stigmatized populations, because everyone has the right to live, and it's our duty to preserve life, no matter what we think, no matter how they may differ from our lifestyles or what our moral or philosophical constructs may be. It's life, and we have to preserve life. The other thing, again, is complacency. There's going to be a point in time when everyone starts to say, this is too much, enough is enough. I'm going to relax my guard. I'm going to drop that precaution, and I'm going to go out and face the world. And certainly, and it's more so at this time, the politicization of the issue can be very, very harmful. And one can start to see certain philosophies that are based on other aspects rather than looking at true science to determine what's necessary. Now, I know a lot of people are wondering about the vaccine. And we know that, as I mentioned, in 2009 with the swine flu, we had a vaccine within a matter of months. And now we're trying to find vaccines for COVID. There are at least 140 programs that are in place to look for virus candidates. There's some companies that are moving into phase 3, and a lot of people say or feel that that means that a vaccine is right around the corner. That's not the case. Vaccines have to go through rigorous scrutiny to be approved. There are actually 6 steps that vaccines have to go through. There's the exploratory step, there's the preclinical research done on animals, there's the clinical development, and that has 3 phases in itself, which looks at safety, which looks at efficacy, which looks at the total efficacy and safety of the product. And then there are regulatory reviews and approvals. Then one has to develop the manufacturing components. And one has to have that manufacturing site approved by the government. And then finally, that site has to be approved to have the appropriate quality controls. So as far as a vaccine coming soon for COVID virus, I'm very, very skeptical about that. Now, COVID-19 is an RNA virus. It's a single strand, which means it can break. And every time there's a break, there's a mutation. And there are a couple of types of mutations. There's an antigenic drift and an antigenic shift. A drift is a minor mutation. Basically, it's the same virus, but just some minor alterations. And then there's a shift, which makes it a very significantly different vaccine, different virus. And one example that we can use with regard to that is polio. We know that we've had a great vaccine for polio that has done wonders. However, because of the mutation of the polio virus, we're starting to see it have lessened effect in certain areas of the world. So as far as the vaccine is concerned, it's difficult to say what's going to happen. Because COVID is mutating, and we know that there are numerous mutations, then that probably explains why the symptoms of COVID are different. It also could explain why some individuals are asymptomatic as opposed to individuals that are not. And it's this asymptomatic nature of the viral disorders that are very, very concerning. As again, people tend to have certain images, certain ideas of who is infected and who is not. And so someone who looks well, who is well, who's not exhibiting any symptoms, no fever, no nothing, one assumes that they don't have the virus. But because they could be an asymptomatic carrier, they have the virus, they're not showing any symptoms, but because they have a viral load, they can pass it on to other individuals. There's been a lot of controversy with regard to children and how children are minimally affected by this, but I can tell you that there have been children that have died. In Ohio, there was a child less than 1 year old that died of COVID. And across the country, we've seen 7-year-olds. We've seen a number of individuals over the age of 10 that have developed COVID and have died from it. So youth does give a certain amount of protection, but it's not absolute. Again, at this time, the best thing we can do is to wear masks, to social distance, and to make sure that we wash hands very, very thoroughly. The other aspect is trying to find a therapy for COVID. And there have been a number of medications that have been evaluated, and so far none have come up to be especially effective. Certainly Gilead and its remdesivir is one of the medications that has shown efficacy, but in my opinion, the efficacy is minimal. It only reduces the temporal effect of the disorder by several days. I don't believe there's any definite information to suggest that it prevents death from those diseases. My opinion is that in the same way that we found a therapy for AIDS, we will mimic that to find an effective therapy for COVID-19. And with regard to AIDS, we took a look at a number of different medicines that showed some activity to combat the disease. And we put those together into a combination of therapies using 3 and 4 drugs. And when that happened, each drug enhanced the activity of the other drug, and we had a cure. I believe that remdesivir is helpful, but we are going to find other medications that will enhance the effectiveness of remdesivir, or perhaps even a new type of vaccines as well. One thing that has recently been touted on the news is oleander. And oleander comes from a plant. There's no data that shows it has any efficacy for the treatment of viruses at all. And I would also mention that oleander is a poison. And so I truly hope that people do not take oleander for this difficulty. It kind of reminds me, I'm an oncologist, kind of reminds me of all the people that spent thousands and thousands of dollars traveling to Mexico to get apricot pits, Laetrile, and it did nothing for them.
I got on it.
So at this point, I know there are a lot of questions, and the last time I did this presentation, there were a lot of questions. And I'd like to kind of open things up to see if there are any questions. Dennis, I see you there contemplating.
Yeah, I am contemplating. I hear so much, and it's so variant. I was talking to somebody who was a chemical corps officer for the Army, and he said the Army's done all these tests, and the masks don't really stop it. And I get professionals like you who are testing it, going, yeah, it does matter. The water does. It doesn't prevent it lying in the air. It prevents coming out of me to get into the air. So I guess I'm getting worn down by the battling professionals.
Yeah, and I think that's the difficulty. I think there's so many people trying to get the limelight that they're presenting information before it's peer reviewed, making suggestions that they've found this and they found that, but they haven't really researched it enough to confirm that. So it's kind of information overload. You know, now we have web, now we have all of these access points to information. And I believe it was revealed that 40% of Americans get their news and information from Facebook. And some of the ridiculous things that are appearing on Facebook are just ludicrous and very, very dangerous. As far as the mask is concerned, there's data to suggest that if you take a look at two populations, one population that wears masks, there is a 50% benefit. In a population that doesn't wear masks, there's only a 5%. So there's a significantly greater amount of safety with the wearing of masks than not. And as I've mentioned, the masks aren't able to filter out the virus. These viruses are nanoparticle size, so a millionth of a millimeter. And so they can go through pretty much any mask whatsoever. But the fact of the matter is, when the virus is expelled from an individual, it is encased in a liquid, a particle of saliva, of phlegm, or what have you. Now, those encasing materials are caught in the mask, and they are less likely to be expelled into the air. So it is more of an important fact that wearing a mask protects others rather than to say that wearing a mask protects you. But remember, if you're out there and someone's wearing a mask, then they're doing that for you. If you're out there and someone's not wearing a mask, well, they're doing that for themselves. So I hope that kind of clarified things, Dennis.
It does. I'm wondering if that's part of the complacency problem, that there's so many messages. So I'll play roulette.
Yeah, no. And let's face it, you know, to say, okay, you live in America, you're used to certain freedoms, certain entertainments and such, but we're going to tell you, you have to stay at home and avoid all of those things. At a certain point in time, it gets pretty old and it gets pretty discouraging, and people are going to say enough is enough, and I'm going to just take my chances.
Dr. Fletcher, regarding the masks, I read something very important. First of all, you can test the mask by holding it and looking, if you can see through it, like sunshine or light, then it's not enough protection. You should have multiple layers.
Right.
T-shirts and things like that are made into masks aren't working. They should have double layers. So there's a difference in a mask. If you wear that has very little protection, you may just not wear a mask. But you're better off to have double layer or some protection more than just a T-shirt or a handkerchief. Handkerchiefs don't work.
Right. Well, currently they have 3-layer masks that actually have an additional filter that you can slide into it. And so those are probably the most effective. But as you mentioned, if you can see through it, if it's very, very thin, then you can understand how those particles, how a sneeze or a cough or an aggressive exhale can cause those particles to
Go through.
get out into the air.
They also showed a mask with those little filters on it that open up when you breathe out, like construction masks.
Yeah.
Those are no good because they open up when you
Exactly. Exactly. They, their idea is to be a barrier, but then they open up the barrier. So
Right.
yeah. But quite frankly, even those are better than nothing.
You could always cover that up when you expel.
That's right. But then you have it on your hands.
This is Belinda Huffman. I'm on the President's Club board. I just joined you. I have a question regarding face shields. Come August the 25th, any direct patient care is now mandated that you wear a face shield. And I know that's for eye protection, but also for additional mask protection as well. So do you foresee something like that starting out in the public community too?
Face shields are definitely inferior to masks because there's all that open air. So again, I can understand that it does offer protection for the eyes, and it offers a certain degree of protection from expelling from the nose or the mouth, but not sufficient enough and not equal to that which can be gained from wearing a mask.
I just didn't know if, adding the face shield to the mask, if that would give added protection out in the community as well.
Oh yeah, I think, again, because now we understand that, certainly we have mucosal tissue, which the virus gains access in the mouth, in the nose, but also there's mucosal tissue in the eye area. And so that's another area for access of the virus. So I'd say a shield or some type of eye guard and a mask would probably be optimal. Actually, even wearing glasses provides some degree of protection. Not enough, but some degree.
How about the ears? Is that another way that the virus can get into your ear?
No, we've not really seen anything associated with the ears. The other thing that I'm curious about is I don't really see a lot of GI contamination, and I'm curious about that because I know that we're now starting to see a lot of GI symptoms associated with COVID, nausea, vomiting, diarrhea, and so is it possible that this is a antigenic drift or shift that has changed the virus? We know, for instance, that originally it was the Wuhan strain of the virus that affected people on the West Coast. But we learned later that it was a mutated European strain that came over and started to affect people on the East Coast. So same virus, different strains, and different types of disorders. The other concerning thing about this, and the thing that young people should understand is that yeah, you can get the virus, and if you're young, you're probably not going to die. But what we do know is that 50% of the individuals that have the virus and have symptoms, those symptoms don't necessarily go away. And so people can have such things as inflammation of the heart area, myocarditis, and that is life-threatening, and that can be with them forever. They can have brain dysfunctions. Some of the presenting signs are associated with nerve involvement, the inability to smell, the inability to taste. That can be altered permanently. So even though you may survive the virus, you may have relatively minimal symptoms, you can have residual effects that can last a long, long time.
Do you think that if you had a positive COVID and you don't seem like you have residual symptoms, could you a month, 2 months, months later develop, symptoms again
Yeah,
with this virus?
that's one of the big questions. We know that immunity from the COVID has a expiration date, and we're not quite sure of what that expiration date is. It could be months, it could be longer. And for all we know, it may even be lifelong, but that's not very likely. So we're still trying to understand that. And that has an implication with regard to vaccine development as
Right.
well. So right
So we-
now, yeah,
So we
right
may
now,
have,
oh, please.
so we may have to be vaccinated every year against it versus just one vaccination.
Right, right, right. And unfortunately, COVID is here, and COVID is going to be with us for decades. I would call to the fact that AIDS was first noted in the 1980s, and at this time we still do not have a vaccine for AIDS, and there's a lot of people that don't have immunity.
Mhm.
What about the research that you're doing now on COVID?
Well, what I tried to do is I tried to take a look at feasibilities and cost efficiency. And certainly I know there are a lot of aspects with regard to intervention, with regard to medications, and certainly vaccine development. But I know those are going to be very, very expensive and take a long time. So I tried to find something that would be effective and practical for the now. And what I've found is my research has shown that when you take a look at individuals who have HIV, who have COVID-19 and have vitamin D deficiencies, they have the greatest amount of severity and mortality associated with that disease. Those individuals who have adequate vitamin D levels are able to survive, and the severity of the disorder is significantly less. We have taken a look at some of the information with regard to ethnicity and the disease, and we know that African Americans are twice as likely to die from COVID as the majority population. We also know that in the majority of population, only about 40% of those individuals have vitamin D deficiencies. However, in the African American population, over 80% have vitamin D deficiencies. And so we've taken a look at numerous studies, we put the data together, and we now understand that having an adequate level of vitamin D can help the body's immune system fight off and quell, sort of blunt the effect of COVID. And so that's one of the things I'm trying to advocate for everyone. Vitamin D, especially vitamin D3, because it tends to be longer. Last longer. We've done a lot of research, so there are products that can give as much as 50,000 international units of vitamin D. But we found that higher doses are less effective than taking smaller doses more regularly. In a nursing home population, because we see a lot of this vitamin D deficiency in the elderly, in nursing home residents, in individuals that have chronic diseases, and in people of color, and who have the greatest severity from the disease, those populations. And so if we can correct vitamin D deficiencies, we can do a lot to reduce the severity and mortality of the disease. And all it takes is 1,000 to 2,000 international units a day of vitamin D. And that is very, very healthy. And it's safe. Vitamin D has been around for a long time. First of all, it's not a vitamin, it's actually a hormone. But vitamin D has been around for a long time. So its track record, its safety is great. As long as you don't take over 4,000 international units a day, you're going to be fine.
How much vitamin D do you get from golfing?
Well, that's the one thing. That's great. Vitamin D is mostly absorbed through sun exposure. And so individuals who spend a lot of time out in the sun get much better levels of vitamin D. People in the northern climates that have less sun have less vitamin D. It also has to do with pigmentation. People who have more pigmentation have less of an ability to absorb vitamin D. And also individuals who tend to live indoors, to work indoors, again, such as nursing home residents, such as factory workers who can't social distance, who can't work from home, they have less of an ability to absorb vitamin D. The other thing is we think about, oh, well, there's vitamin D in milk and there's vitamin D in this and that. Only 10 to 20% of your vitamin D is absorbed from the diet. So the sun is extremely important with regard to that. And if you can't get it from the sun, then you need to get it from a supplement.
What about blood type? I've been hearing that certain blood types are more prone or...
Yes, we've done some
About that.
statistical analysis, and actually we found out a lot of strange things that could be associated with other factors, but this kind of holds true. It seems that people that have type A blood have a greater difficulty with COVID-19. We've also found out things such as in China, they found out that people who took the advanced medications for heartburn, the Prilosec types, had more of a difficulty with COVID than the people that took the lesser medications like Pepcid. So people took a look at that, and so the question is it actually the medicine, or is it because the people who take Pepcid can't afford to take the Prilosec, and because they're in a different social economic strata, they have greater potential for exposure? There's also been controversy about ACE inhibitors, blood pressure medicines that are commonly used by a number of individuals. The ACE2 pathway has been associated with how the COVID gets into the cell. And there's been a lot of research. At first it was said that if you take an ACE inhibitor, then you have a greater propensity to develop the virus or to get the virus. But now studies seem to negate that. So it seems as though the ACE inhibitors are safe for you to continue to take. But because we're still learning, because we have so many information gaps with regard to that disease, we're just coming up with new ideas, and we're starting to dispel a lot of old ideas. Remember, at first, mask wearing was not necessarily something that everyone was promoting. And now it's the #1 thing that's promoting. So that has a tendency to erode our confidence in the science. But unfortunately, science, true science, validated science, science that is obtained using the scientific method takes time.
This is Belinda. I'm sorry, I had to take a phone call. I heard all about the vitamin D, but the vitamin C you mentioned
Oh,
prior to
no.
that?
Certainly vitamin C is helpful for the body. Zinc is helpful for the body. There are a number of other factors, but we have been able to confine and to determine our research has focused on vitamin D.
Okay.
And we find that very, very hopeful because vitamin D is readily accessible. Any drugstore, any supermarket, you can get vitamin D. It costs maybe $1 or $2, and it's safe, and it doesn't cause any significant difficulty. So it's something that can be implemented right now and could save thousands of lives.
And I know that I've had relatives that had COVID positive, symptomatic, pretty severe respiratory, not enough to shortness of breath and send them to the hospital. But they said that as soon as they took zinc, a pretty high level of zinc for a couple of days to avoid toxicity, it kind of turned them around.
Well, we know that zinc does have an antiviral effect. However, there's not been enough scientific evidence to show that zinc is effective with regard to COVID-19. What vitamin D does, it actually has a number of different functions. It actually turns on the T cells and the helper T cells, which are the soldiers, shall we say, of our immune system that battle the disease. And they're unlike the proteins, the gamma globulins, the substances that are produced by B cells. We find out, and it's thought that younger people probably do better because they have a better T cell response than older people. Because as you get older, your T cell response is diminished.
I'm taking neuroferon. Do you think that's anything that's
I'm not familiar with that
interesting?
particular.
It's supposed to, help to build your cells, rejuvenate your T cells and that. So that's.
The difficulty is, again, like the oleander, and there are so many people that are trying to make a fast buck, and they're advertising like crazy over the web to say, oh, I've got this cure and this cure and this cure. They say, oh, we have a lot of evidence. There was a doctor who was on TV who was touting how effective hydrochloroquine could be in treating the disorder. And she had treated hundreds of patients and had success. I haven't seen any data on those hundreds of people. I know that there have been a number of studies that have looked at large groups of people that have shown that it's not effective. And in fact, the cardiac risk and other risks, including blindness, that are associated with hydrochloroquine far outweigh the benefits that are noted there.
Ron, how do people, or can people of older age improve their T cell response? Is there something I can be doing, shouldn't be doing?
Well, again, diet certainly has a lot to do with it. Exercise has a lot to do with it. But you're kind of limited as how well you can improve your immune system. Certainly, as I mentioned, such things as vitamin D, vitamin C, all those can help your immune system. But there are certain practical aspects. Actually, meditation can actually help. We did some experiments.
Really?
We did some experiments with cancer patients. And we had the patients visualize cells that had them think of them as Pac-Man and how they were gobbling up the cancer cells. And in fact, the study showed that those individuals that did that visualization did better than those that did not. So our mental status can have a lot to do with how we can help ourselves. Okay, well, again, if there are no further questions, I would, oh,
Any other questions? This has been to me, I really enjoyed hearing you again. I learned, even though I heard it the first time, I learned a lot more the second time. And this is videotape. So any other questions?
Oh, I just want to say thank you too. This was very informative.
oh, I appreciate that.
The-
I want to
Same
make,
here.
I want to make one final statement, and that is, consider this pandemic a dress rehearsal, because we know that there are viruses that are potentially out there that can get into the human population. And quite frankly, I'm very concerned about chickens as being a vector for future pandemics. But we've already recognized some viruses that have that potential. And unfortunately, because more and more countries are becoming interested in this gain of function studies, which can accidentally release something that can be devastating. So we're bad now, but unfortunately in the future, it could be a lot worse.
I have one question that I'm toying with. What was it that was put in place regarding pandemics by the previous administration that was eliminated today? And if that would have been something that could have prevented a lot happening today?
There was a viral surveillance group that was funded by the government. They essentially assessed the viral risk all over the world, and sort of acted as an early warning system to let people know what was coming. There were also preparations for a viral pandemic. As you know, during the last administration, there were difficulties with Ebola and a couple of other viral disorders. And so they were aware that this could happen again. And remember, there were some Ebola cases in the United States. Fortunately, they were individuals that had come from Africa, and they were isolated immediately. And so that prevented what could have been a horrendous difficulty. There's another virus that's called Marburg's virus, and it is also one of these hemolytic viruses. It ravaged through Europe for a period of time. I'm kind of scared about that. The mortality rate of Marburg virus and Ebola is over 80%. So again, there are a lot of bad things out there, and we have to have a much better system for early detection, because that's the only way that we can protect ourselves. If we've got an enemy in which we have nothing to combat it, nothing to protect ourselves, then the best thing we can do is to make sure that we are aware of its presence as soon as possible, so we can do everything practical to prevent it from spreading.
Thank you. Great presentation. Thank you.
Can I ask you, why did you say chickens' future pandemic spread? Is this
Well,
deemed to be where they get spread from?
well, we already know that there have been pandemics associated with avian, with chickens. So we already have models to understand that happens. But we've also started to recognize other potential viral threats in poultry. And because poultry is so widely used around the world, as a matter of fact, I believe they found coronavirus in a shipment of poultry from China. But because it's very difficult to get coronavirus through eating something that's been cooked, because the cooking usually kills off the virus. But again, it's how we raise chickens now. You know, everything is on an industrial level. So instead of having 10 chickens in 10 coops, we've got 100,000 chickens in one yard. And they're interacting, and whatever one has, the next thing you know, 100,000 have it. And so that is passed on to the human population again and again and again, to the point in which it mutates to a type that can travel from chickens to humans.
That's scary.
It is. It is.
My family that had COVID positive in them has chicken coops.
Yeah, yeah. Well, again, as I said, it's mainly a difficulty that we find in third world countries, but also in the mega countries, the countries that have multiple billions in population.
Yeah.
First of all, they are dependent on that particular protein, and so it's very, very well spread throughout the population. And the conditions in which they raise those birds is not good.
Yeah. Wow. Good information.
Are there any other questions?
I do have
Doc-
one, if nobody else has one. Can you go back over what gain of function is and how that can allow viruses to escape?
Right. Gain of functions is a line of study in which we take a look at viruses and we manipulate the genotype of the virus. And we manipulate the genotype so we can see what other aspects may present from that virus. We try to find out how minor mutations might cause major differences in how that virus acts. Because we're doing these genotype changes, then a lot of times that can cause the virus to have increased transmittability. And that's one of the things gain of function is trying to do, to try to see if we can take a virus that is only noted to occur in, say, bats, and see if somehow a coming mutation might allow it to occur in humans. So we're trying to push the schedule up a bit to see what factors will make that worse, more transmittable, more deadly. And as I said, unfortunately, this can only be performed in a biosafety level 4, which is the highest level of safety facility. And in China, there was one, and they're trying to develop others. In Taiwan, I believe they have 4. They are beginning to have more and more in the United States. As I mentioned previously, gain of function was prohibited, but more recently it's been allowed to recur again. So that people should be concerned about these gain of function research projects.
Ron, it's Bill and Sue. Thank you so much for this presentation.
Hey, good to hear from you folks.
Yeah, you know why we're not on visual, right?
Probably because you're practicing Tai Chi. No, believe me, everyone, it's been a great pleasure. Like I said, I really want to do something to help with regard to this disorder. And I feel that if we are armed with information and understand some of the simple things we can do to best protect ourselves, then that's a way in which I can help. Maybe I can only help 100 or 1,000 people, but hey, that's 100 or 1,000 people that don't have to worry about dying from this disorder.
Thank you. I said, God
Thank you,
bless you.
Ron. Thank you,
God bless
Ron.
everyone.
Take care, everyone.
Thank
Have a
you.
wonderful
Thank
day.
God bless.
Stay safe,
Thank
be
you.
well.
Thank you.
Thank you.
Okay, everybody, have a great week and be safe.
Thanks, Tony.
Thanks, Tony. Come on.